for joining us session today. And firstly, I would like to invite Dr. Thaila Ramanujam, Chief Executive Officer of AYIR West Logan Chapter, to present the introduction to the Association of Women in Rheumatology, please.
So I am not Dr. Thaila Ramanujam, but I will start as the slides are in that order. I am Professor Grace Wright, founder and president of the Association of Women in Rheumatology, and my first talk today will be on sex differences in autoimmunity with a focus on psoriatic arthritis, and this data goes back now a few years that we've been looking to see, are we all the same, or are there differences that we need to understand? So when we first think through this, we know that autoimmunity is much more prevalent in women across the board, and that these are the things that are highly expressed in our female patients, and there are lots of ideas around what drives that, and we think of various sex hormones, genetics, epigenetic variables that are now coming into full play, but also that there are viruses and toxins that may integrate and impact our autoimmune response, leading to a greater expression of autoimmunity in women. It's not across the board. What we see here in red is female, in that bluish color is green, and so you'll see that the things that we take care of, systemic lupus, vasculitis, Sjogren's, even Hashimoto's thyroiditis, rheumatoid arthritis, the neurological diseases, celiac is even more highly prevalent in women. But when you get to diabetes and Crohn's and ankylosing spondylitis, myocarditis, and primary biliary cholangitis, that becomes a male-dominant autoimmune disease. So it's not universal that autoimmunity is in the purview of women only. And there are a few reasons that have been identified for this. And if we just look at this wheel here, starting at the top, on the far right, we see that we've got genetic factors, and those are the ones here identified. So those are genes on the X chromosome that are not inactivated. Remember, when we have XX pairing, there is this gene that comes in to suppress, to deactivate one of those so that you don't have double expression. And now we think that there is some dysregulation in cyst inactivation that allows for autoimmunity to be expressed. But there are other genes like FOXP3, which we have known about for a long time in rheumatoid arthritis, that can lead to dysregulation of the T regulatory cells in our females, leading to higher autoimmunity. When we think about environmental factors, well, that goes across the board. Chemicals and infections have been implicated there. And then some of the other genetic factors are autoimmune regulatory genes that are dysregulated, downregulated, so there's greater autoimmune expression. That's the AIRE gene, and that can also be impacted by viruses and chemicals and various hormones as well. So a nicer model here to show how these things sort of intersect is if we start off on the, I would say the top right, where we see all of the endocrine disruptors, which include things like BPA, we'll see that there's increased DNA methylation that occurs there, but that is a recurring theme that we'll see increased DNA methylation in multiple others. So for instance, hormones also lead to increased DNA methylation. And then we've got our microRNA extracellular vesicles, which is really a newer concept that we have, that cells can transfer content cell to cell with endocytosis of these vesicles, carrying genetic material, microRNAs, mitochondrial DNA. I think I just lost it just stopped projecting. There we go. Carrying mitochondrial DNA that bypasses that cell's nuclear programming and then sort of sets it on a different path. And so you can override a cell's primary function. And so with that, with these extracellular vesicles, which we see here both in terms of impacts on endocrine, impacts on infections, and also some of the chromosomal dysregulations with toll-like receptors. So when we think about it, it's more than just saying, oh, it's because women have estrogen and men don't. There are all of these factors at play in a positive and negative factor that lead to this. So now if we use psoriatic arthritis as one disease to say, how do we see this difference being expressed and the impact here on both disease burden and treatment outcomes, and do we treat everybody the same regardless of how they come in? So now we're going back to 2018, and this was a gender difference, this was a Danish healthcare registry study looking at gender differences in biologic treatment outcomes across almost 2,000 patients with PSA. And the idea here was to say, are there differences in the disease manifestations, in the outcomes that patient reports, their PROs, the comorbidities that they experience, and the treatment effectiveness associated with their first TNF inhibitor. So this is just looking at TNF inhibitors. And I'll give you the summation of this was that the male gender was strongly associated with greater TNF effectiveness. So if I have a man and a woman walk into the room, he's much more likely to respond. She's not doing something wrong, she's just less likely to respond. And this was true regardless of all of the modifications and statistics that were done to remove confounders. We then looked at this in with secukinumab, looking at the IL-17 class now. And this now goes back, I think we published this a few years ago, but comparing the secukinumab versus adalimumab efficacy, and then went into the post hoc sex stratification to see, was there a difference seen in this trial as well? And the first thing that we came across in the analysis was that people were starting from different levels. So the disease burden that women had was higher across multiple measures, but also the disease experience of women was different than men. And we tend to use the same terms and the same outcome measures and the same ways in which we, the same adjectives that we put in front of names, but their experience was different and the disease burden was higher. And we also saw behaviors that were different. Smoking was in transition, so now we have more women smoking than we used to have. Tender joints was different, pain, function, and enthesitis was different. So the very things they all walked in, and remember, this was an RCT, so they were already stratified. So the first thing we saw, this was the primary outcome of this analysis, was that there was no difference between the IL-17, which was secukinumab here, and the TNF inhibitor, which was adalimumab, dosed accordingly. So it looks like they're the same, and this was designed as, this became a non-inferior outcome, so it was a negative response. But when you then looked at the women versus the men, a few things started to emerge. So when you see here, the females are on the left, males are on the right, secukinumab is in blue, adalimumab is in red, and in both cases, and this is a PASI 90, so in skin there was a difference, and in the PASI 90 score, secukinumab, the IL-17, did better than the TNF. But the men always did better than the women, point for point. So there was a difference in their outcomes using this very objective measure, PASI 90. The baselines here are single-digit numbers. When you looked at function, you also started to see this peeking through, where there was a difference again in function between 17s and TNFs that were seen with women, but there was no difference that was seen with men. Again, this is a post hoc analysis. This wasn't sort of the pre-stratification. What about enthesitis? Enthesitis is a thing that interrupts people from even starting their action, and we saw these numbers were really not so significantly different, except the women had lower enthesitis responses than the men. So if she comes in with enthesitis and he comes in, he did better than she did from an enthesitis response measure. So the summary of this was that in the SUCCEED trial, which was designed to look at secukinumab versus adalimumab, that females here walked in with a higher disease burden. Their baseline activity was higher compared with men. The treatment responses were lower across multiple musculoskeletal endpoints, comparing the IL-17 to adalimumab. And this went all the way out through week 52. And so that was our first inkling that maybe there was a difference that we were not capturing because we were not stratifying by sex in our clinical trials. So then this analysis was also done with ixekizumab and showing the same things here. On the top right, you'll see the ACR 20, 50, 70. Men are on the left, females on the right. And without looking at the exact numbers, everything is shifted up for men. So the men did better. And then when you look here at the more stringent measures, or sort of the CDAPSA, where they're looking at remission or low disease activity, the men were more likely to achieve that than the women. So the next question was to say, well, we've left the TNF, 2 IL-17s. What about ustekinumab, an IL-23 inhibitor? Are we going to see the same difference here? And the prequel is the same. Now we have a better understanding that their differences are pulling through even in our advanced targeted therapies. And so this was the PSA Bio study, which was a multinational sort of a large study to look at the effects of gender on disease characteristics and the treatment impact in patients with PSA. Now, this becomes important when you're doing registry analysis, because if we lump everybody together and we don't power this to look at differences across these key endpoints, you sort of wash over those differences. So here we see, this is almost 1,000 patients enrolled. We had baseline data. They got their ustekinumab. Data was collected up to 3 years, but every 6 months. And lo and behold, a very similar story was told. Women here in the lighter blue, men in the brighter blue. So for each point, whether it's minimal disease activity, which is where you meet 5 of the 7 endpoints in that composite score, or very low disease activity, you meet all 7, the most stringent, the men still fared better. So there was something here that said, is this disease, is this drug, are we not sort of designing the drugs and asking the right questions when we go to trial? And then we looked at treatment persistence over the course of a year, and lo and behold, women were falling off the curve, right? So treatment persistence says the time to discontinuation or switch, and the curves for women was much lower. I just realized I have a pointer here. Oops, nope. The curves for women were lower, so they were falling off therapy much, much faster. The other thing that was seen here was from the safety analysis, there was a higher proportion of adverse events in female patients, and this was both treatment-related and by DMARD discontinuation due to treatment-related effects compared to men. So they did worse, and they had more adverse effects, and so they fell off the curve, and hence would require a switch much more frequently. So now we're seeing some differences, and so this is a real-world data analysis. All comers come in. You're doing as much matching that you can, and it's substantiated here that women had more severe disease. Both genders experienced improvement, but men experienced a little bit more than women, and women stopped or switched more frequently. So the story evolves. And then now, this is this is a change in the sex distribution of PSA. From male to female dominance was noted, so we're going from thinking that this was a male dominant to, in some data sets, in the French data set, it now became female dominant, so the ratio is 1.2 to 1. And what led to that is unclear. But when they looked at this analysis to say, I'm looking at TNFs, IL-17s, IL-12/23s, IL-23s, and now we have the new kid on the block, the JAK inhibitors. Is there a difference that was seen in this particular study? And what they also found was 52%. The Kaplan-Meier survival analysis showed that overall persistence of targeted therapies was higher lower for women, 52%, compared to 62% of men. But when you broke it apart even more, TNFs and IL-17s, persistence was lower for women for those two classes. But when you looked at the 12/23s, the 23 and the JAK inhibitor, it was not. So there now was the inkling of a difference in effects based on pathway, and was there a difference that we could now go back to those very first slides to say, what are the epigenetic modifications? What are the extracellular vesicles doing? What are the hormones doing? What is the T regulatory cells? And how does that come into play? So conclusions here were, as I said, and that we needed to really have sex-based and gender-based studies to better understand this. And then the final one I want to leave you with, and this was sort of really telling, because I've always been interested in population analyses, because we can't treat everybody as if everybody is the same. There are genetic differences that may come into play. So this was a severe plaque psoriasis study in an Asian population. This was a systematic literature review with a network meta-analysis. And just to sort of give you the top level, looking at a variety of agents, so now we're going to have apremilast as a pill, deucravacitinib as a pill, and then we have a host of biologics, adalimumab, certolizumab, so all the TNFs, including infliximab, the 23s with ustekinumab and risankizumab, and then we have guselkumab in there, and the 17s, secukinumab and ixekizumab. Lots of IMABs in there. And what was really striking here was that whereas most everything was on that purple line, apremilast was much, much lower in an Asian cohort compared to the general registrational trials, where everything sort of washed out to be the same. So it's important also not just to look at the impact of sex and gender, but also regionally, what are the differences across various other cohorts, whether they be identified by race or otherwise. So the key takeaways from this, just as a peekaboo into autoimmunity, is that most, but not all, autoimmune diseases occur more often in women than in men, more highly expressed there, multiple key factors that we've talked about that are now under investigation, much more investigation, that women walk in with psoriatic arthritis with more disease burden. The other thing that I didn't highlight here in one of these studies was that the joints affected were different. So men had more axial disease, women had more enthesitis, men had more dactylitis, and so the women walk in with peripheral dominant, and the men walked in with axial dominant disease. And persistence was clearly different across. So I always come back to, well, why do I care about this? And we care because it means that perhaps we should be doing things differently, that in order for us to think about optimizing management of psoriatic arthritis, regardless of what therapies that we're using, if we want to have the same high outcomes for all of our patients, we need to think about how we study this differently, using sex-based and gender-based studies to identify the mechanisms, and then to do real head-to-head stratified analyses. And the first trial is actually now being run, Lower Coats is part of that, looking at a sex-stratified study in psoriatic arthritis to see if we can tease apart what's driving this, and perhaps how do we better personalize this with evidence-based outcomes. So thank you for your time and attention. I tried to speak very slowly, and hopefully, you caught every word. So I'm going to invite Dr. Ramanujam up to do now what would have been the first slide deck. Thank you. If you look at gout as a marker of autoinflammatory, what we've seen in the past 1 to 2 decades is an increasing predominance of gout in women. Now, whether that is environmental, behavioral, dietary, all of those things, or are we seeing the same things that are shifting prevalence, as we saw here with the extracellular vesicles, the autoimmune regulatory genes, sort of all of those things that are occurring, the epigenetic modifications that will affect the inflammasome as well. So as we start to unpack what's happening in what we're calling autoimmune diseases, we will inevitably unpack what happens in autoinflammatory. We're seeing this now when we look at obesity as an immunologic disease, right, where you have adipose cells transferring microRNA and pieces of DNA and mitochondria into adjacent cells and driving an inflammatory immunologic response. So, as this shifts, right, we'll have to look at the impact of air pollutants, oral pollutants, drinking water, various toxins, and all of those, because even gout is changing.
I have a question.
Yes.
Thank you very much for your very interesting presentation. I would like to have a question. Why do you choose the disease like spondyloarthropathy, like psoriasis and axial arthropathy, spondylarthropathy, ankylosing spondylitis in your study? Because I think is the men they have always suffer from this kind of disease. And the second, you present some factor, risk factor is the sex difference, the infection, the HLA or environment. And in your opinion, the sex difference is account for how much, how percentage for the contributing to the autoimmune diseases, and the secondly, which risk factor are predominant in the woman, because I very surprised that the autoimmune disease in women is frequent and more severe in the woman, and the prevalence of treatment, of a result of treatment is lower, and so I would like to know why.
So partly why, and I'll go back to this slide, is it's an issue of where we have the data. The idea was that psoriatic arthritis was male-dominant disease. And then it became clear that we were wrong. We were not identifying psoriatic arthritis in women because we were missing the way women presented and the language that they used to describe their symptoms. And the same was true for axial spondyloarthritis. So as I said, women will come in complaining of pelvic pain, not buttock pain. And so we don't hear it. They come in with peripheral disease, not spondylitic, not axial disease. And so there was an underdiagnosis of women. They would then have a much longer delay to diagnosis, and so they presented with worse disease. But it wasn't that their disease was destined to be worse. So in this was sort of the space where we went from a 45 to 55 to becoming now predominantly 55 to 60 female to male. So there's clearly a shift, and is it just that we're diagnosing it, or are there other things? So this was a space in which we had research to say we understood something about the hormones, we understood something about the genetics, and so you can start to unpack it. But where else do we see this? We see this in lupus, which is highly female dominant, but when we have men, they may have worse disease. So is it always the same things that are leading to the sex-based differences? We don't know until we look. Rheumatoid arthritis, again, is predominantly female. And there is some inkling, but because the presentation tends to be quite similar, it's peripheral symmetric disease, you start to say, well, do we have comorbidities that are different? When we look at lung and splenic involvement and myocardial involvement, is that different? But there wasn't enough analyses being done because we just weren't thinking about that as a difference in terms of severity and presentation. So I start with PSA because that's where I went, there's something that we're missing, but it's not because I think that's the only place that we need to do that analysis. Because when you look here, for instance, so women are dominant right through here. When you get into the GI space, you start to see male-dominant autoimmunity. So it's not that it's always sex hormones, XX or estrogen driving it, because clearly you have autoimmune diseases that are much more prevalent in men than in women. It can't be the same thing. There has to be something else in play. So that's where the story started, but it's not where it's going to end. We have to do the analysis and the primary research to figure that out. So that's why I chose this. And I had 20 minutes, and I could not do this all in 20 minutes.
Thank you. Thank you very much. Oh, now I would like to invite to Dr. Thaila Ramanujam to have a speech on introduction to the Association of Women in Rheumatology, please.
Thank you very much. How much time do I have?
20 minutes.
30 minutes? 20 minutes, okay. Thank you so much. I want to,
Okay.
Okay. Okay. So I want to thank you all. I am thrilled to be presenting this information. I want to give you a little bit of the history of aware in rheumatology, and I want to take some time to explain how you as ambassadors might be able to help them to collaborate going forward in terms of forming some kind of an association that will be mutually beneficial. So to start with, I want to, I'm thrilled to introduce Dr. Wright, who was the founding member and has been the president of this organization for 11 years. So the brief history, so our mission truly are bookends of two issues that I think we will relate to. On one end, we want to promote scientific understanding of rheumatic diseases, and on the other end, we want to be able to help provide sufficient care for our patients and develop good systems to bring the best outcome for our patients. So those are the bookend understanding of what we want to accomplish, which is identical to what Professor Land mentioned yesterday as to what your mission statement for your VRA is. But at the core of this, our organization, is the spirit, our understanding that there is advocacy necessary. We have to advocate for ourselves as providers. We have to advocate for people who are underrepresented, underprivileged, underserved. And at the end of it, we want to truly elevate our patient care and our patient understanding of these diseases. So that's really where we come together as an organization. And I want to throw a few terminology that I think truly captures our spirit. So obviously we want to accomplish these goals with excellence. That's our benchmark. And we want to do it with integrity. And certainly reaching out and building communities, not rheumatology communities, not just in the US, but also globally through communication. So I think that's really where we are most excited to be here this time, to be able to connect with you guys. And at the end of it, and I think you will relate to this as well, because last night at the opening ceremony, we saw how excited and fun and adventurous you are. And I think we bring the same spirit to our organization. We want to do all of this, but we want to do it with fun and joy in our hearts. And this is a group of women, and this sort of tells you where we are in our diversity. Bunch of women, different races, different ethnicity, different cultures, different location in the US, different ages, different aspects of our profession. Some of us are early in our career, some of us are much more advanced. We are in private practice, we are in academia. This is the spectrum that we want to reach out to. And I think every community brings its own spectrum and its own diversity. I want to highlight that this is a volunteer organization. It's a nonprofit organization. We are all volunteers. We all have day jobs. We do different things. But we come out of the joy in our hearts and our dedication to this mission to really work as volunteers. And we've done so for nearly 10 years. And we started out with 1 or 2 local chapters in the US. Now we have 50 plus local chapters in the United States. And we reach out to over 11,000 global members. And I talk about what it is that we can bring to you. Obviously, the 3 factors are research, and we have a lot of offerings, educational information that's free to our global members, and I want to highlight some of those. And I truly we believe in advocacy. So we do advocacy a certain way in America based on what our legislations are, how we influence our strategies in terms of our own survival within the ecosystem and also how we help our patients. Each country, in our experience, seems to have its own need for advocacy issues. And so we don't need to bring our issues here. We are here to listen to what your issues are and how we might be able to support you in devising or collaborating with us to be able to solve your own problems. So we are most open in the forthcoming years ahead to really understand what your advocacy needs might be. And young rheumatologists are at the core of our heart. We really want to encourage the youth. We want to support the early career rheumatologists. And a lot of our educational material that's offered for free is really geared towards influencing and encouraging and actually even recruiting medical students and young residents to really go into the field of rheumatology, because we do think there's going to be a burgeoning need for rheumatologists as providers going forward because of our MSK diseases that are really going up in terms of our aging population and such. And we have Dr. Carr, who you will meet in future. And these are some of the studies, ideas of the kind of studies that we publish. So we're looking for disparity in representation and how to evaluate based on what kind of disease activity, what kind of medications we use, our insurance coverage. So these are germane to our situation in the US. and we want to understand the differences in how these factors affect the outcome. And I want to show you this map. We are purple, our color is purple. We adopted the color, and it has really stuck very nicely with us. None of us are in purple, but we will show you how purple this map looks, because this is really where our members come from. And not all the countries that we have members in are our partners, but Vietnam is a partner. So there are 16 such partners, and I want to highlight how some of the partners are in the northern USA, some in central and southern United States, and the UK, Italy, Morocco, and Ghana. And in the Far East, we have the triad of Pakistan, India, and Bangladesh, and Australia. And of course, Vietnam is our very special partner, and we hope to really continue our communication with you guys. And in terms of our offerings, the free membership offering, there is this immunology boot camp. You can actually, it's on demand. You can go access it anytime. And these are not just limited to members. It's available to anybody who can go on our website. And you can pull all of this data that was CME credited at our organization. But in terms of understanding the immunology of our diseases, how does a B cell expression affect our diseases? The JAK inhibitors, the tyrosine kinases, the Bruton tyrosine kinases, the dendritic cell receptors. So these are important players in our diseases, and you can access this boot camp and understand who the key players are and how to influence them in terms of modifying the disease process. And Nuts and Bolts is an offering that's given to all our, anybody who wants it, and it's really developed by a very thought leaders in the field who are our faculty members, who are looking at, created the content of this, that look at primarily educating young rheumatologists. What are some practical tips based on the scientific data available to us? How do we do data analytics? How do we truly develop a treatment plan that help elevate the patient care and to really help outcome globally? Now, there are some members-only content. So if you become a member, which is a free membership, all you need to go is to go to the website and become a member. It's very easy. And you will be sent links to some of this data that is really geared towards what we think is our flagship of our operation, which is our annual meetings and all of the content of the meetings, which is a 4-day, very tour de force of scientific information and clinical data that is present and available to you. Because of the 12-hour difference, you cannot join us virtually live at these meetings, which you could if you were able to, but you have access to that information. Now, every year we do what is called virtual summits. There are 4 each year, approximately, and there are 2 that have already taken place. But this, again, brings Dr. Land's information, how we need to cross-pollinate our information and our learning, because we need other specialists to come into the fold. So these are really geared towards bringing dermatologists and immunologists and obesity specialists into the fold in terms of our conversation about how to influence our patients and develop. So the complimentary registration for the annual meeting, it is truly an amazing experience. If you all happen to be in the United States or able to come at the time, please do join us. It is really one of our best programs. You can access the material later on, but what we could also do is to invite young rheumatologists, fellows, or just 2 years out of fellowship, to really submit abstract presentation. And this is an opportunity for you to really go on a global platform to be able to present your material, scientific material, and it's all for free. And if you submitted it when it's a call to submission, we will be able to go through the screening process, select. You can either present this virtually or in a video, or if you are able to, come to us. We would love to showcase you and your talents on our platform. So as I already said, young people are at the core of this message, and we would love to have you participate in it. And if you have any questions about this, kindly reach out to us. And I'm happy to answer any questions that you might have at the moment.
Thank you very much for presenting your organization to our young doctor. And I think it's very interesting because we have a chance of collaboration.
Yes.
Yes. And can you suggest some film of collaboration with the young rheumatologist and VRA? Yes, in the future.
Yes, absolutely. So some of the studies that we, sorry?
Okay, continue.
Yeah, sorry. Some of the things that we are doing in the US is looking at regional differences in how disease is present, how they manifest, and how they respond to treatment. And what are the factors that affect the different responses? For instance, we know that there are portions in the US that have a higher use of steroids. That sort of changes the outcome measures that we use. And we're also really promoting the idea of what we think is patient participation in our treatment. So with the patient information, bringing the patient into the fold in terms of a decision that we make and the decision strategies that we use, because that really enhances adherence to treatment and better outcomes. So these are some of the ideas that we could use in Vietnam to see if there is perhaps a difference between one region and another in terms of how disease is present, maybe the north and south, whatever your regional differences are. We could model some of your studies the way we have structured our studies in our questions that we have asked. So we might be able to support you design those studies perhaps. This is just an idea. I'm not proposing anything in particular. I'm really looking for questions on your side that we can help you with. But that would be an example to look at regional differences.
Yes. Another my question to you is that, and you are a part of American Rheumatology Association, or you are in autonomous association, and is your, for example, the result of your research can implement to the and present to the session of American Rheumatology Association, or published on the international level or not?
Right. So we are an autonomous, completely independent of other organizations in the US. So we have our own ability, because we do our annual meetings, we have the ability to really have 800 or upwards of 800 members who participate in our program. And we are able to get the young rheumatologists who submit abstracts to us, have a committee that decides who would be eligible for the presentation. There is a podium presentation and there's also abstract presentation. So we're able to encourage young rheumatologists all over the world to join us in that effort.
Okay, it's very good.
All of the clinical research that we've done has been presented at both ACR and EULAR. So our posters and podium presentations are presented across. We work with different countries, either working with their national organization, for instance, working with VRA, or working with the Italian Rheumatology Association, or sometimes it's a group within the country that does the work, but we work across all levels. We're all embedded in the American College of Rheumatology in terms of leadership and all of the roles that we do. Most of those roles are actually occupied by AWARE members. But I also want to highlight the fact that we may be an association of women, but 1/3 of our members are men. So we include everybody. So I don't want to hear the men saying, oh, we can't join because we're a man. everybody can join. And I think the link is already on the VRA website, so easy to do, but we really want to, and we encourage everybody. We have the young ones who are just coming out, and then we have those who have served for 60 years and have retired, or they're professors emeritus. So you get the full spectrum, and the nice thing is that you get the mentorship and sponsorship. So if I have an idea about a trial, I can call Professor Calabrese. I can text Len and say, I have an idea. What do you think about this, right? Because there are those who know more and can do more and can advise more or open a door for a pathway to say, here's where you should go to look at this. Like, for instance, we're starting a global consortium looking at air pollutants and lupus flares. And that's going to be across the US, Canada, and India. So those are the sorts of things that you can have the connections, and then that gets presented at EULAR. We have 2 submissions to APLAR in Japan this year as well. So the work that we do gets acknowledged and seen on all the global congresses. So that's the whole idea, right? We want to give visibility where visibility may not be quite as honed, and on issues that we think are important.
Oh, thank you very much. I think we have a lot of chance to collaborate each other in the future.
Yes.
Thank you very much.
Very good. So
Yes.
we are hoping to have a Zoom call scheduled, and we invite all our men and women, young rheumatologists, everybody is welcome to join in, and we may be able to take the next steps together. So I thank you for your attention.
Yeah, thank you.
Chúng ta qua được báo cáo của hai diễn giả người Mỹ về cái điều cũng là mới với nước mình, hội nữ khớp học. Dạ. Bây giờ chúng ta sang phần trình bày của các nhà khoa học trẻ Việt Nam, nhưng mà bằng tiếng Anh. Chúng tôi giới thiệu đầu tiên đấy là bác sĩ nội trú Lưu Cảnh Linh từ Đại học Y Hà Nội, về cái đề tài là bệnh cơ hoại tử qua trung gian miễn dịch, trình bày ca lâm sàng, case study. Ok, mời anh.
And thank you for being here today. And my name is Liu Cảnh-Linh, and I'm excited to share with you 2 case report of immune-mediated necrotizing myopathy. And throughout this presentation, I will explore 2 cases of this kind of disease and some review of literature. And I hope you will find it both informative and engaging. First, I would like to talk something about this kind of disease, immune-mediated necrotizing myopathy, or IMNM, firstly described in 1916. And it is usually classified as poliomyositis. The incidence of IMNM is rare, accounting for approximately 10% of all idiopathic inflammatory myopathy. It had 3 types of disease with different clinical symptoms, severity, and prognosis. The typical symptoms is often acute or subacute muscle weakness, myalgia, and very high levels of creatine kinase without any typical skin lesions of dermatomyositis. It has 2 specific antibodies, anti-SRP and anti-HMG-CR. So far, there is no official diagnostic criteria or treatment guideline, and often the prognosis is poor. The main treatment is steroid, immunosuppressive therapy, and IVIG. Now we come to the first case presentation. We have a 73-year-old female patient with a past medical history of heart failure with reduced ejection fraction. She was treated by many medications, which included rosuvastatin, 20 milligrams per day for 2 years. But one year ago, she experienced muscle pain, especially in the thighs. And the liver and muscle enzyme tests gradually increased. The doctor suspected that is because of the side effect of statin. So the patient stopped taking statin for 6 months, but the symptoms did not improve. And 1 month ago, she suffered from severe muscle pain in the thighs and slowly progressive weakness in the lower limbs when climbing stairs or walking, and she was admitted to the hospital. The patient presented with muscle weakness predominantly in the lower proximal limbs with a muscle strength grade 4 out of 5. Distal limb strength and upper limb strength were both preserved at 5 out of 5, and no skin rash were observed. The laboratory tests revealed a significant elevated CK levels of more than 6,000 and increased GOT and GPT. Needle EMG show muscle damage and no nerve damage detected. And the patient was biopsy of the left quadricep show central necrosis of muscle fibers, and there is no inflammatory cell infiltration. And this patient has a specific antibody test. The anti-HMG-CR was positive. Here is a picture of the muscle biopsy of the quadricep. You can see that in the arrow, that is the necrotic fibers. And the patient was diagnosed with IMNM with positive anti-HMG-CR. The initial treatment included prednisone at 1 milligram per kilogram and methotrexate at 0.3 milligram per kilogram per week. And after 1 month, she still experienced dull pain in the thigh muscles and bilateral muscle weakness, but she tells us that it is partially improved. And the laboratory tests show a significant improvement. The CK levels reduced to nearly 2,500. And we continue to use the prednisone and methotrexate with the same dose for the patient. Here is a second case. Now we have a 33-year-old female with a past medical history of hepatitis B. 2 weeks prior to admission, she experienced muscle pain and weakness in both lower and upper limbs, which became more apparent when climbing stairs or walking, leading to hospital admission. On admission, the muscle strength were assessed as follows: the lower and upper limb, the proximal muscle strength is 3 out of 5, but the distal strength remained preserved 5 out of 5. And other organs have not detected anything special. The laboratory tests show the significant increase the CK level and the GOT and GPT. The needle EMG show the same as the first patient, muscle damage, but no nerve damage detected. And she also has the biopsy of the left quadricep, but it had no central necrosis of muscle fiber, but in the muscle, there is very little inflammatory cell infiltration. She also had a specific antibody test, anti-SRP positive, and she was diagnosed IMNM with anti-SRP positive, and the initial treatment the same like the first patient. But after 10 days, the patient started to experience chest pain and palpitations at night, and she was readmitted to the hospital. On admission, the muscle strength is really weaker than 10 days before, with the proximal muscle strength 2 or 3 out of 5. And the laboratory tests show a significant elevated troponin T, but the echocardiography and the ECG show no significant abnormality. And we suspected that it's a subclinical cardiac involvement, and the patient has a very severe muscle weakness. And the young age is a very poor prognostic factor in this kind of disease. So we decided to bolus 500 milligram methylprednisolone in 3 days, and then with dose reduction to 1 milligram prednisone per kilogram per day plus methotrexate. And luckily, after 1 month, the CK level reduced to nearly 800, and the GOT and GPT level became normal, but the muscle strength partially improves. Here are 2 cases of IMNM that are treated at Hanoi Medical University Hospital. And now I would like to talk about some review of literature. IMNM can be categorized into 3 main subtypes: anti-SRP positive, anti-HMG-CR positive, and seronegative IMNM. Anti-SRP positive accounts for 5 to 50% of IIM, and typically affects individual age 40 to 15 years, and it is more common in women. Anti-HMG-CR positive represent for 6 to 5% of IIM and occurs more frequently in women more than 40 years old, and notably 15 to 65% of patients with anti-HMG-CR has a past medical history exposed to statin before. Another type of this disease is seronegative IMNM. It is recently individualized in 2011, and it accounts for 10 to 12% of cases. The age of onset, the gender ratio, it is similar to seropositive IMNM, and it has to be found to be associated with cancer. So here are the chart above show the percentage of anti-HMG-CR positive patients with prior statin exposure. You can see that in North America, their statin exposure can be varies from 40% to nearly 100%. In Asia, the exposure rates range from 13.6% to 59%. So when a patient takes statin, how long does it take from statin commencement to a myopathy? Then here's the answer. Multiple cohorts report a significant delay from statin commencement to onset of symptoms of anti-HMG-CR-IMNM. The delay typically around 3 years, but it can be as short as 2 months. 2 months and as long as 14 years. So what are the clinical manifestations? It varies based on the serostatus. The seropositive IMNM typically presents with severe and very severe proximal muscle weakness, which is often sudden and acute, like the second patient, it predominantly affected the lower limbs with the muscle strength rated at 2 to 3 out of 5 in anti-SRP positive cases. Additional symptoms like difficulty swallowing or myalgia can be met. In some cases, with the chronic manifestation, the patient can have symptoms called scapular winking, and it needs to be distinguished with a genetic disease called limb girdle muscular dystrophy, especially in young patients. And in some patients with seropositive IMNM, the laboratory tests show extremely elevated creatine kinase level. It can be more than 30-fold the upper limit level. So what about the seronegative IMNM? The symptoms is the same like seropositive, but the phenotype, but no reports of slow disease onset. So what are the extramuscular involvement like other IIM disease? But I need to emphasize that IMNM is a muscle predominant autoimmune disease with the very little extramuscular damage. Especially in anti-SRP positive, you can see some patients have interstitial lung disease, but often typically no symptoms. Myocarditis can be seen in some patients with some cardiac signs, and it occurs in 2 to 14%. But in anti-HMG-CR and seronegative IMNM often show no extramuscular manifestation. Here are this slide presents the association between IMNM and the cancer risk. Seronegative IMNM significantly increase the risk by 8-fold, particularly the gastrointestinal and the lung cancer. It is important to note that the risk of malignancy is typically observed within 3 years before and after the diagnosis of the myopathy. This slide demonstrates some histopathological hallmarks of IMNM. Firstly, we can observe that the necrotic fibers are randomly distributed throughout the biopsy. And in chronic IMNM, you can see that some fibrous tissue representing different stages of muscle damage and repair processes. And MHC class 1 positivity, and you can see some deposition of the membrane attack complex in the sarcolemma. Here is a phenotypic comparison between anti-SRP and anti-HMG-CR IMNM. In terms of epidemiology, they are tending to be similar. But regarding to the clinical features, anti-SRP is associated with more severe muscle deficits and muscle damage. Both they have very high level of CK, but the cardiac and the lung involvement is commonly observed in anti-SRP. And one important distinction is the presence of the anti-HMG-CR and anti-SRP positive. So what are some differential diagnoses? So statin myotoxicity and some other forms of IIM. Statin myotoxicity can present in 4 different forms: asymptomatic, myalgia, myopathy, and rhabdomyolysis. But typically, it has an early onset after statin's commencement. But in contrast, IMNM often has a delayed onset, occurring months to years. But regarding to resolution, most statin myotoxicity cases resolve with statin cessation, but IMNMs do not. And a very important feature of IMNM is the presence of anti-HMG-CR positive. And some kinds of IIM can be misdiagnosed with IMNM. And IMNM is characterized by severe proximal muscle weakness. And a very important features is that histopathological of the muscle biopsy that can help us to distinguish between with other IIMs. And of course, the seropositive antibodies can help us to distinguish between other IIMs. So what is the treatment of this kind of disease? But it's, so far, it is mostly empirical, based on clinical experience. There is no official guideline in the treatment of this kind of disease. Prednisone monotherapy is generally insufficient. So the combination therapy is often needed. Methotrexate is typically the first choice, but in cases of intolerance, you can select azathioprine or mycophenolate mofetil. For severe cases, intravenous IVIG and rituximab can be selected. And one needs to remember is that the reintroduction of statin may trigger a flare. Here is a general IMNM prognosis. In general, IMNM is challenging to treat. Only about 50% of patients with anti-SRP IMNM achieve normal or near normal strength after 4 years of treatment. And the similar result with anti-HMG-CR after 2 years. And the young onset is a poor prognosis. And I would like to come to some conclusion. IMNM is a muscle-specific autoimmune disease. For the diagnosis, anti-HMG-CR and anti-SRP are very essential. Anti-SRP positive are more likely to develop the myocarditis and interstitial lung disease. But seronegative IMNM are associated with a higher risk of cancer. And IMNM is the most severe in terms of muscle-related morbidities and is of long duration. And thank you for your listening.
Thank you very much. And now I would like to introduce Dr. Ngô Thị Trang, Bạch Mai Hospital, to have a speech on subchondral bone remodeling, a therapeutic target for osteoarthritis. You have 15 minutes to present.
Yeah, dear esteemed of college, my name is Ngô Thị Trang, and I'm from Rheumatology Center, Bạch Mai Hospital. Today I want to tell you an interesting topic, and is related my result in specialty 2. It's called subchondral bone remodeling, a therapeutic target for osteoarthritis. My presentation divides 3 main parts. First is anatomy and function of subchondral bone. Next one is subchondral bone remodeling in OR. And the last one, the current and future therapies for OR subchondral bone remodeling. As you know that osteoarthritis is the most common disease leading to cause of pain and disability in aging population. It is characterized by catalytic damage change in subchondral bone, osteophyte, muscle weakness and inflammation in synovium, tissue and tendon. The OR considered a primary disorder of articular cartilage, but nowadays the physiology of subchondral bone is play around interest, and subchondral bone remodeling plays a crucial role in the international and progression of OR. This is the anatomy of subchondral bone. As this picture, you can see that subchondral bone is the part underlying the cartilage and tidal mark. It has two main parts. This is the subchondral bone plate and subchondral bone tubercular. And it has two functions. The first is shock absorbing and supportive function, and the next one is supply catalytic nutrition. As you know that catalytic is not have a artery or venous, and so subchondral bone give the artery or venous vessel nervous and into the cartilage. And in OR, what the trend is in subchondral bone, you can see in histopathological feature in osteoarthritis. You see that have a lot of micro damage, bone marrow edema, and the last one is subchondral bone cyst. In this picture, you can see in the MRI film, you see that have the bone marrow edema. You see the increased signal in T2 weight, and the next one is bone cyst. And this picture overviews that how the cartilage, how the chondral bone, and how the tidal mark trend in during the OR progression. In this one, in normal joint, the cartilage is intact and the tidal mark only one curve. And the next one is the early OR. Although cartilage still intact, but the subchondral plate thickness and lost the rod like tubercular and meet thickening of plate like tubercular. And the late OR, we see that lost cartilage, we have a lot of osteophyte, and the subchondral bone is thickened and becomes the sclerosis. And next one, what is the subchondral bone in OR? You see subchondral bone remodeling when in the OR patient, subchondral bone undergoes remodeling. And this trend occurs both within the cells and extracellularly in the subchondral bone. And in the cell, you see the osteoclast, mononuclear cells, osteoblastic trend, and the bone extracellular matrix. And what is the trend in the osteoclast? In osteoclast, the progression of osteoclast tendency is increased, so leading to increased osteoclast. With two factors play a crucial role in rank and capsaicin K. And the mononuclear cell is the progress that so far little know about this, including clearing away the resorption debris. And in osteoblast, the hyperallopatric activity relieves the rank transformation, and some factors like TGF-beta-1, TGF-1, and VAGF is elevated OR osteoblast. And with this progress, sclerosis bone is occur. And what is the current and future therapies for OR subchondral bone remodeling? In subchondral bone remodeling, we have some organ for inhibiting the osteoclast, the regular osteogenesis, osteocytes, and other components like vascularization and nerve. And this picture overview what is the cellular target in the subcoronal bone remodeling. You see that the organ will intact in the osteoblast, in the mesenchymal stem cell, in osteophyte and blood vessel and nervous. First is inhibiting osteoclast in subcoronal bone. We talk more about before for that. Is the drug have a many research in the people and in the animal, and in that research they said that the bifosfat can relieve subcoronal bone pathology trend to against the radiographic knee osteoarthritis progression, and two drug is upset is alendronate and zoledronate. Next one is calcitonin. Calcitonin is a 32 amino acid hormone, and it can prevent loss of subcoronal bone tubercular. But in fact, it not involvement in joint space and pain relief, and it have a long risk of cancer if we use it a long time. Next one is estrogen. Estrogen, in some research, it can lower prevalence of knee OR, and some drug can use it rilosenphine and tibolone. Sodium retinate, with dose is 1 and 2 grams per day, it can improve pain and physical OR function, but it's not. It have a lot of side effect on cardiovascular system, so you need to consider to use in the OR patient. Next one is teriparatide. Teriparatide is called directly influence articular bone and articular cartilage, and bone growth, but it not have the random clinical trial for achieving OR in fact. And some four potential OR subtypes are purple. You can see is bone acting organs to NSAID and mesenchymal stem cells, subcoronal bone, or regulative therapy. And next one, we talk about the future therapeutic in targets. The therapeutic in the future therapeutic often research in the in vitro in animal which not improve in the patient the people. So we want to introduce a little bit about this. The first is inhibiting osteoclast capsaicin K inhibitor. The second, some organ can regulating osteoblast like TGF beta, WNT, and other Chinese herbicides. Some therapeutic for osteocytes and some therapeutic for vascularization and nerve innervation. And the last one is regenerative therapy. It's capsaicin K inhibitor. They said that it can delay our progression or against the subcoronal bone loss and to partial elevation for cartilage. Some drug can use is odacansacid, but it have a lot of side effects on the cardiovascular. Some other organs like TGF beta or other Chinese herbs can use some animal have protect the OR and to reduce the OR progress. Osteocyte is it one the pathology of OR. It can leading to pain or reduce the activity of the patient. And they said that if you use the organ to COP2 inhibitor for 4 weeks, you can make the people relieve pain and relieve the catalytic degeneration in the mice. Vascular relation with the OR patient, they said that the overexpressing of planet liver grow, and if you use a drug like benzimazumab, you can prevent the cervical, including OR progression. The nerve intervention for nutrient 1 can help the people reduce the pain in for animals reduce the pain in the in vitro. And the next one is regenerative therapy. Is the stem-based therapy. The most important that the surgeon need to use the fluoroscopy to redirect the choker to the subcoronal bone marrow lesion. It helps the subcoronal bone help the people reduce the pain and recover the subcoronal bone in the patient. Thank you for your attention, and I hope pleased to answer any question you might. Thank you.
Oh, thank you very much for your presentation. And at the last, I would like to invite Dr. Trần Ngọc Hữu Đức from the Chợ Rẫy Hospital in the South Ho Chi Minh City to talk about the tumor-induced osteomalacia, a case report and literature review, please.
Yeah, thank you for your kind introduction. Good afternoon, everybody. So I believe that everyone is now very starving. We are hungry now, so I will start very, very quickly. So let's start with the patient. I have a patient, male patient, a young male patient, born in 1990. He was gardener and he lives at Dong Nai province, a province in the south of Vietnam. The history started in the late of 2019 with low back pain. The pain worsened at night, and there was a muscle spasm when the patient was sleeping. And in the morning, when the patient moves, the pain will improve a little bit. Then the patient went to another hospital where he was diagnosed with ankylosing spondylitis. And with this pain, inflammatory pain, back pain, low back pain, he was diagnosed with ankylosing spondylitis, and the treatment was initiated, but there was no improvement. Then the patient stopped the treatment, and he took the herbal medicinal treatment, traditional Vietnamese herbal treatment, and there was no improvement too. By 2022, he noticed that there was a mass about just a little bit 1 centimeter in the left thigh. And in the early 2024, the weakness progressed very rapidly, and then he came to us. We met him in May 2024, and he was wheelchaired and severe kypho scoliosis and forelimb weakness with the muscle strength about 3/5. And the joint examination showed no joint involvement and no deformities at the head, face, neck, or the other extremities. The lab tests are normal, except for the phosphorus is very low. Inorganic phosphorus very low, about 2.8 milligram per liter. And because of the ankylosing spondylitis, a pelvic X-ray was performed, and the radiologist read that there is a blurred edge of bilateral SI joint that suggests ankylosing spondylitis. And HLA-B27 is negative. And a severe bone pain suggests us about something about the bone, so a DXA was performed. And the DXA show a very low bone densitometry at T-score at the neck level, -5, T-score at the hip level, -4. At this age, this is very, very low at this age. And X-ray show here is a fracture of the sternum, the fracture of the pelvis here, and a multiple fracture. So we continue to do the test because at this time a diagnosis of osteoporosis cannot explain the disease of the patient. He is quite young for osteoporosis, so we continue to do it. We try to do the other causes of secondary osteoporosis, and PTH was quite high And we do MRI because the patient has weakness. And MRI show osteoporotic vertebral collapse in the cervical and thoracic regions. And then we perform FGF23, intact FGF23, and show the results show very high results, more than 4,000. So a diagnosis of tumor-induced osteomalacia was made at this time. We try to locate the mass. We try to locate the mass with PET-CT scan, and the PET-CT scan was performed. And as we can see here, there is a mass at the left thigh, and at this time the mass is quite bigger. It's bigger than 1 centimeter. Several years ago, just 1 centimeter, but this time it's very large now. And the diagnosis is tumor-induced osteomalacia, and he was admitted to our hospital for an excision surgery in July 2024. And this is the mass here, and this is the pathology. The pathology is characterized by the spindle-shaped cells here, the spindle-shaped cells. And this is one osteoclast that we all know what is osteoclast here. And there are many microvascularization inside the tumor. So after the resection, as you can see here, in July, in August, he came back and he was still wheelchaired. In November, he can move freely. And you see the phosphorus level, 2.8. After the resection, it returns to normal. And FGF23, 4,000 here, down to 70. So after the resection, the patient was completely cured. This is the MRI after the resection. You see there is no more tumor here, because the cost of PET-CT scan is very high. So we do not perform PET-CT scan again, but just an MRI. And the MRI show there is no sign of the tumor here. You can see this is the patient. He can move freely. Yeah. So let's talk about the literature review about the epidemiology. We all know that TIO, or tumor-induced osteomalacia, is a very rare disease. So the epidemiology will be based on just the case reports. For example, a report from Japan, show that the prevalence is about 0.04 per 100,000 people per year. So very rare disease. And there is no disparities between male and female patients. And the mechanism, we can see here the main role of FGF23. FGF23 is proposed to be secreted by tumor cells, and FGF23 will affect on both the intestine and the kidney. At the kidney level, it affects on the co-transporter of sodium and phosphate. It will inhibit this, and it causes the phosphate resorption, reduce the phosphate resorption, and it causes the phosphate secretion via the urine. So without the phosphate, the patient will have not enough mineralization of the bone, and so the fracture will occur. And without the phosphate, phosphate is a part of what is called ATP. ATP is the main energy of the muscle. So that's why our patient has the weakness, the muscle weakness, because of low ATP. And at the level of intestine, FGF23 will inhibit vitamin D. So low vitamin D, low phosphate and again hypophosphatemia and cause the musculoskeletal disorders. In the literature review, we all know that in our patient's spindle cell, and here you can see the spindle cells, osteoclast like giant cells, in our patient is the same. Capillary vasculature is the same in our patients. And this test, they use in situ hybridization for FGF23 mRNA. And you see that there is the expression of the FGF23 mRNA in the tissue here as brown color. So this proves that FGF23 has the main role in the pathophysiology of the disease. For the clinical manifestations, non-specific bone pain is present in almost patients, 99%, non-specific bone pain. And the tumors are often asymptomatic unless located in the nasal sinus with the symptoms of obstruction of the nasal sinus or the bleeding of the sinus. And often resulting in wheelchair use, as in my patient. And the misdiagnosis with ankylosing spondylitis is very common. So I will skip this. For the imaging, you will see that there is a very characteristic sign, the loser zones. This is the loser zones, the microfracture of the bone. The loser zones is characteristic of osteomalacia and TIO, tumor-induced osteomalacia. So the loser zone is seen in this film. But the fracture will slow after the resection of the tumor, so there is no need to do a repeat X-ray. For the lab test, we will see that there is hypophosphatemia. So phosphate is low in all patients. And there are several indices to measure the phosphate in the serum, such as tubular resorption of phosphate, or TRP, or maximum tubular phosphate resorption per glomerular filtration rate is quite long, TMP per GFR. You can use this nomogram to calculate as this formula in the slide. FGF23 can be measured, and there is 2 types of FGF23 in the market. First is intact, and the second is C-terminal FGF23. And both of them are not validated in the clinical trials because the disease is very rare, so there is no study designed for the validation of the test. But you can use the normal reference range of the laboratory test of the lab. We do not have a standardization of the test, but we can use the threshold of the lab test. FGF23 is elevated in almost all TIO cases. There are 16 reported cases of TIO with normal FGF23, but the authors say that if this is a correct diagnosis or not. 16 with normal FGF23, is this a correct diagnosis TIO? For the tumor localization, we know that TIO is tumor, and this tumor has a nature of what is called neuroendocrinal tumor with the expression of a receptor SSTR, somatostatin receptor. And we use dotatat. Dotatat is favored because it has high affinity to SSTR, and dotatat is labeled by gallium-16. This is used in PET-CT scan. So we use PET-CT scan to localize the tumor and to prove that this tumor secretes FGF23. For the treatment, so obviously, the total resection of the tumor will cure the disease. So the treatment is surgery. Surgery is the first choice. But in our hospital, we manage about, in my department, we manage about 5 to 6, I don't remember exactly the number, 6 patients with TIO. About 3 of them, we cannot find the tumor. We cannot locate the tumors. So in this case, we will treat them with conventional medical treatment. We give the patient phosphate, element phosphate. But you know, phosphate is very hard to find in the market. We have several pills, phosphate pill, but it is used in the treat the animal diseases, not for human. So we use fleet enema for our patients because there is phosphate inside. But the patient will have diarrhea after taking it. So for the take-home messages, TIO is a paraneoplastic syndrome. But it is only benign tumor. It is not malignant tumor. It is only a benign tumor caused by the overproduction of FGF23, with severe complications, multiple fractures. And we will locate with 68 gallium dotatate. And to my knowledge, my hospital is the only hospital in the south of Vietnam that has this technique. And the surgery is optimal treatment option. So thank you.
Thank you very much for our 3 young researchers, and thank you very much all participants today in our session. Very interesting in English. But you, dear guests, our guests, you know, there are 3 presentations come from the north of Vietnam, the Bạch Mai Hospital and the Hanoi Medical University Hospital. They are the 2 centers for medicine in Vietnam. And the third in the Chợ Rẫy Hospital in Ho Chi Minh City, and in the north, in the south of Vietnam. And you know, now Vietnam can diagnose the very rare diseases. And so we have a good platform for diagnostic and treatment. And we use in this research, we use modern technology like in immunohistochemistry and PET-CT, MRI, and immunological test. And so the result of our research is very encouraging. And so I would like to know your opinion, and I hope that collaboration between our Vietnamese young researcher and your organization will be developed. And can you have some speech on that? Your opinion, please.
Thank you. So the cases that you presented are, submit them, right? So for oral presentations, it's 7 minutes, so you get to do a much abbreviated. You would present one of these cases. What we look for are cases that are unique, where there is evidence-based, there's a diagnostic, there's a learning. So all of these can be submitted, right? And you know, we have, last year we had 60 fellows presenting for us, but this is a sort of thing where it gives you a wider platform. You know, you get another platform, right, to present on. And if it's not accepted as an oral, then it's accepted as a poster presentation, in which case you have a poster that we then share for the entire Congress. So it sort of amplifies the very excellent work that you've done. And one of my pet peeves is people not recognizing the excellence that occurs in medicine in other parts of the world. And so it's a way to showcase the thinking, the intellect, the diagnostic, and outcomes. The therapies that we may have available, just because we may have them more readily, are different. So for instance, the necrotizing myopathy would have gotten rituximab immediately. IVIG and rituximab, like boom, because we have access to that quite easily, and we know that it's going to give us a better outcome faster. But that's only in cases where you have that available. So what do you do when you don't, right? And so this is an issue of how do we teach, because it's not every, in the US we're very insurance stratified, so your insurance may not approve of that. And so if you're not aware of the research and the therapeutic outcomes in other areas, then that's very helpful. But again, these cases are fantastic, and I applaud you on your diagnostics and your therapy and the way you sort of walked through the presentation. Well done, very well done. So these are the sorts of things that we would love to showcase as well. And then when thinking about North and South, I always am fascinated with the differences you see with disease presentations and outcomes. And you have 5 cases of a rare thing in the world. 5! You're probably now the expert. The expert on that. So this is a sort of thing that I find rather exciting. So yes, many different things, and of course, we are open and available for your ideas and thoughts of what you want. And yes, we are heavily invested in our young rheumatologists, but we're invested in all rheumatologists, so you can drag one of your seniors along with you, right? But the presentations, we keep them for our young people. So thank you so much for inviting us and for being here. Thank you.
And I would like to invite all the participants to have a photo.
A photo. Of course.
Okay.